sincere thanks to all of our experts and our patient community, which is really, really exciting to be sitting alongside Fong this evening. We met 2 years ago at the Colon Club, and it just opened a brand new chapter in my life, certainly. I know it did similar for her. So to have the chance to work together on this kind of joint venture is really, really exciting, and hopefully that leads to many more. So I just maybe have Fong say a few words, and then we can introduce some of the things that we have going on with our organizations.
Yeah, I think organizationally, you know, Fight CRC and Golden Club have always shared this special relationship. It's been tremendous support of each other, and we strongly believe in what each other do. So we're tremendously excited to be able to share this with you, and that we'll be taking the next steps forward with sharing all this information and just having a great conversation.
Superb. So I actually, because of the Colon Club, I was introduced to fight colorectal cancer, and that came to life at Colon Congress in 2019. And if you haven't been, it's an absolutely fantastic event. One of the things we wanted to let you know is that we're launching a brand new advocacy portal, which lets you experience, you know, everything you need to know about advocating for change on behalf of colorectal cancer patients. That goes live next Tuesday. If you skip to the next slide, Sharon, we've also got our Beyond Blue magazine going out tomorrow. It's just a fantastic digest of so many things that are going on in the colorectal cancer world. So I just urge you to have a read of that. It's virtual this time. It looks absolutely fantastic. So there is no paper version, but do download the virtual copy, and waiting rooms everywhere. And then, of course, we've got Climb for a Cure coming up in August 15th. And it's really a major jewel in our calendar crown this year. So hopefully you can join us for that virtual event. Conscious we're not going to Squaw Valley this year, but anything you can do to make up those 1 million steps for 1 million survivors at home in your own turf will be much appreciated. So look forward to seeing more people take part in that. Fong, over to you.
And the Colon Club sponsors a retreat once a year. Out of it comes this On the Rise magazine. If you've ever taken a look through, it's the most amazing display of just powerful stories about all different kinds of things that you face when you're a colorectal cancer patient. Caregivers are included in there, and that's a new piece that we brought recently in the last couple of years. And it really rounds out the full picture. So I encourage all of you to keep a lookout for it. In November, we'll open up applications again for our next retreat. So you can certainly find that online in our store, and we'll be able to send those out if you'd like to take a look at that as well.
I was just to add to Fong's description, I was in treatment on Monday and met a 47-year-old patient, just very newly diagnosed with stage 4 colorectal cancer, and basically looking for some hope and inspiration. And I was able to share this year's On the Rise magazine with him and just leave him reading that. So it's a very, very valuable tool, Fong, as you know. But over to our special guest. We're delighted to have some experts on the panel this evening. I've done enough talking, so I'm going to get them to introduce themselves. So Dr. Fields, would you like to just say a few words of hello and introduce yourself?
Sure. Hello, good evening or afternoon, everyone. Thank you guys for having me, and it's just a remarkable group of people coming together from all the organizations. My name is Ryan Fields. I'm the Chief of Surgical Oncology at Siteman Cancer Center in Washington University in St. Louis. A big part of my practice is taking care of patients with colon cancer, typically when it's metastasized to the liver. And I spend about half my time running a translational research laboratory trying to understand better how and why metastasis occurs. And I'm grateful to the hundreds and thousands of patients who have contributed tissue and time and energy to making some of that research possible. So I look forward to participating and having a great conversation tonight. Thank you.
And also with us is Dr. Kathy Eng. You know, I've known her name for far and wide and long time, you know, standing, because many of her patients are actually with the Colon Club. So we get to hear the buzz about all the wonderful things she's doing as well.
It makes me sound so old.
No, you're just that good.
I'm Kathy Eng. I'm at Vanderbilt Ingram Cancer Center. I'm a medical oncologist professor here. I conduct clinical research in phase 1 to phase 3 clinical trials. for our predominantly refractory colorectal cancer patient population. So thank you so much for inviting me. It's my pleasure.
Superb. Mike, I was going to ask you to say a few words. I think you'll be known actually to many of our viewers this evening, but you know, thanks to your great publicity work. But if you could say hello and just say why you're on with us this evening.
Yeah, thank you. Mike Mancini. I'm a stage 4 colon cancer patient and survivor. I was diagnosed at age 42 in June of 2017. I'm currently going under 12 more rounds of FOLFOX and Avastin. I've got the pump on right now. Let's see. I'm on my second recurrence since diagnosis. I'm from Wolcott, Connecticut. I work full-time as a senior manager in customer service operations for a small commercial business for a large insurance company. I'm pursuing my MBA at night, and I'm really active in terms of health and fitness. I really believe in, you know, keeping a strong mind and body, and that helps me fight and you know, pursue through the chemo. And I just completed my first year as an ambassador with Fight CRC. I've got my Climb for a Cure shirt on. I'm ready to go for August. So just thankful to be here today, and thanks for inviting me.
Also with us is Dr. Joel Malin. You know, when we thought about what we wanted from this town hall, one of the critical components we felt was mental health and how do we deal with this craziness. So Dr. Malin, I'll let you share all your qualifications and I won't step on you.
Well, thanks, Fong. It's an honor to be here with you all tonight. I'm not a clinician, so I don't directly interface with patients on a daily basis like many of the heroes here tonight, but I do research. I'm an associate professor at the Keck School of Medicine, and we look at the long-term outcomes among survivors of cancer, primarily young adults, of both pediatric and young adult cancers. And you know, one of the outcomes we're interested in include, you know, resilience and positive mental health and well-being outcomes.
Candace, I'm about to ask you to introduce yourself, but just for everybody who's listening at the moment, we need your questions. So if you want to use the chat that's alongside Zoom, then you know that really sort of fire up the conversation. So please feel free. Anything in the world of COVID, colorectal cancer, and obviously where those two worlds meet is of particular interest this evening. So please fire in your questions. We're really keen to hear from you. But Candace, I mean, I speak to Angie Davis, and I think she talks about you nearly every other day. So I feel like I know you already. But for the sake of those that haven't met you, could you introduce yourself, please?
Hi, yes, I'm Candace Henley. I am a 17-year colon cancer survivor. I'm also the founder of the Blue Hat Foundation. And I'm a serial advocate on so many levels now. I can't keep up because it just seems like these just fall in my lap as it relates to my own personal cancer journey. So I'm happy to be a part of the panel, and I'm also a caregiver for my mom who had COVID-19. And she survived. She survived.
That is great news. I think that this eminently qualifies you to be on this panel. So thanks so much for taking part. I'm glad to see that the questions are already coming in. So as we allow those to sort of fill up a little bit, Devin, I think you were going to kick us off with one of our video questions, weren't you?
I'm going to pause you there. We actually also have Joanna Morales. Want to make sure we introduce her as well. So if you could please.
I do apologize.
Oh, you're on mute.
I'm Joanna Morales. I'm the CEO of Triage Cancer, and I'm actually a cancer rights attorney by training. And I've spent the better part of the last few decades teaching people how to navigate employment issues, insurance, financial topics, disability benefits, and all of the other legal and practical issues that come up after a cancer diagnosis.
Okay, I'll do a take two then. So as I say, the questions are coming in. Sharon's asked if those can go in the Q&A feature. So if you're able to access that, that would be fantastic. But Devin, if you could kick us off, we've got a question to do with immunocompromisation.
Hello, my name is Ed Gallagher, calling from Arlington, Virginia, just across the river from Washington, D.C. I'm a stage 4 colorectal cancer patient, currently undergoing chemotherapy. My question is this. I have 2 apartments overseas in Europe undergoing renovation that I want to supervise. My oncologist has approved a regimen that'll work. So I'm going because the destination is actually safer than here in the US. So not only for this long-term flight, but maybe for short-term flights for other people, what precautions should I take? For example, I have an older N95 mask, unused. Should I wear that instead of just a cloth mask? And any other recommendations that you have. Thank you very much.
Okay, so does anyone want to pick that up? Kathy, you are top left in my screen at the moment, so I wonder if you might want to take a first stab at answering that.
Yes, I mean, I'm happy to do so. So I get asked this question all the time. I completely understand where he's coming from, especially if he has a second home in another country and he wants to supervise its renovation. I've basically been telling all patients that when if they are traveling by plane, I do recommend they wear an N95 mask, or at least one of the KN95 masks versus a cloth mask or just one of those disposable surgical masks. I think that it's the appropriate approach. I also recommend that patients bring handy wipes for the plane, and I ask them to wear gloves on the plane. I think that just it's better to be overly cautious from my perspective. I'm not opposed to the patient traveling. I just want to make sure that, number one, before he gets on the plane, if he's on chemotherapy, it's not during the time frame when his white blood cell counts are going to be at its lowest, which is about 7 to 10 days following chemotherapy administration. So I would probably recommend he get a blood count checked right before, 24 or 48 hours before he gets on the plane, just to make sure that that's not an issue, and just to make sure he appropriately has everything to wipe down his area. I would, even though the plane looks clean, I would wipe down everything. I'm just overly cautious.
Yeah, I mean, I would agree with all of those points and say that, the one encouraging thing I guess that we see is that, and again, we've known about this virus for months, not years, but in the first month, everybody was bringing home their groceries and bleaching them and not taking Amazon packages and things. I think we've learned, at least for the most part, that transmission is not from surfaces, but they're from contacts and respiratory. So, I think that the main things to concentrate on and focus on are when you're in those closer environments and close to people, is making sure that the mask is on and you're wearing it properly, and that you're cautious about any unnecessary interactions, whether it's within the airport or on your way from point to point. But I think, as Kathy said, we can't all stay home forever. It makes sense to be able to travel for our mental health and for our general well-being. Same goes for being outside and exercising and things like that. So we just have to do it cautiously. And being on active chemotherapy is I think similar to being older. There's these risk factors that if they all add up, that may be a prohibitive risk, but on their own are not prohibitive for things like travel.
Hi, I just recently traveled during this crisis from Chicago to Seattle, and they have those like 3-ounce travel bottles, and what I took was I mixed a bleach and water solution, and I also had paper towels in a Ziploc bag. So when I got to my seat, I wiped the seat down, and additionally, to make sure that for me, that I was comfortable. Also, they're not serving food or drink on flights. I don't know if that's changed yet. So carry an empty water bottle or refillable water bottle and bring you snacks because there isn't being anything served on the plane, and that's just so that you're covered for the flight duration. And I also wore long sleeves just so that my skin wouldn't touch any of the seats, anything. And I wore clothes that once I made it to the airport, I went into the bathroom and changed out my clothes into another outfit. So those are things that you can do to help you feel comfortable.
And I do want to mention, thank you, Candace, that's excellent. And I fully agree with everything you said. And also, I know it sounds a bit OCD, but you may also want to think about your shoes. So when I get home from work, I Lysol my sneakers, the bottom of my sneakers. So I just, because you don't want to track it inside the house. I literally change, as Candace stated, as soon as I get home from work, I change in the farthest room in my house before I go into the rest of the house.
I mean, it's an extra precaution. We're cancer survivors, so it may seem a little bit extreme, but I would rather be extreme than than not. And I take off my shoes at the door, and then once I come in, I wipe the door handles down. So I mean, it's almost as if you really have to have an OCD set of mind to kind of backtrack and follow, to make sure that you've covered your bases. And in addition to having hand sanitizer, washing your hands, and just making sure that for you, you're safe. It doesn't matter what anybody else sees or thinks.
And don't forget to wipe down the safety belt on the plane.
That's a good one. I think most of us forget that the seatbelts, how many hands touch that. Along these lines, a couple of questions here that are kind of related. How much does CRC in active treatment increase our risk of COVID? And somebody else had said similar, I've seen 3 studies regarding COVID and cancer. ASCO one, the one from Memorial Sloan Kettering, and the last from NIH or NCI. Which patients are at most risk? Dr. Fields, you want to take that one?
Sure. I mean, I think big picture, it kind of goes to what Kathy was saying initially in terms of checking your counts and things. It's the patients with the most compromised immune systems, and that could be a combination of an autoimmune condition or a pre-existing condition not cancer related, but also a cancer diagnosis where the immune system is weakened, and then of course being on active therapy. And I think there's different buckets of active therapy where the risk of being on chemotherapy versus immune therapy may be very different. And fortunately, everybody that's on treatment has, the person who's most in charge of their care, their treating oncologist, who's probably the best person to be able to guide them on a lot of specifics because they know them best. But overall, I think those are all risk factors, much like we know this affects people with other comorbidities like diabetes and heart disease and obesity more, and older people tend to get it more severely. So I think when we add these things together, those are higher risk. All 3 of the studies that have been published, certainly have a thematic picture that patients with cancer are at higher risk of COVID and should take extra precautions, especially those on active treatment. So, if there's travel that you're on the fence on and you can avoid it or do it virtually, it's probably a good idea to do that if you can. If there's a way to delay certain things or time it around when your counts are at their highest or you're at your strongest immune system, those would probably be the best things to try to do.
Okay. So we have a couple of questions coming in about policy, which is clearly a subject close to many of our hearts. Just one for the experts. How have you seen policy priorities around CRC change as a consequence of the COVID environment? So I don't know if someone wants to stick their hand up and answer. If not, I'll pick on somebody.
All right. So can you elaborate a little bit more? Maybe I'm missing the point of the question.
So in terms of legislative priorities, have they adjusted in terms of the sort of short-term emergency response or some of the long-term goals that we would be trying to deliver on behalf of the CRC community that is also facing COVID? So has that adjusted any of the approaches?
I think there are a couple of things that have come up that I think are very positive, and I'll separate them into one research related. There's now a tremendous amount of funding initiatives to try to better understand not just coronavirus and COVID in general and all the vaccine work, but also its intersection with other diseases, especially cancer. So I think we're going to be able to learn a lot because there are funding priorities to do that through the NCI. And the second thing that I think has made a huge difference in the way we currently treat patients in the coronavirus era and will in the future for everyone is telemedicine. And it used to be, on March 1st of 2020, I had never, meaning zero, done a telemedicine consult. And now about a quarter of my practice is telemedicine because it makes so much sense. And the reason that we didn't do it before is because it wasn't reimbursable. You couldn't get paid to do it. And now it's like no different than if I see you in the office. And CMS and Medicare and insurance companies are reimbursing for it. And I think the most important thing that we can do to advocate is that it continue post-COVID in the future, because right now it's temporary, but being able to do that, the flexibility to say, if I operate on a patient, they don't need to drive back 100 miles for a post-op visit, or their initial consult can be telemedicine and they can come in for some testing that they can maybe do locally. And then I've even met patients that I'm doing liver surgery on the day of surgery, because you can Zoom and FaceTime, and it's a very comfortable relationship. And I think it's a really positive move. I'd be curious to see Mike or other patients have had a positive experience with that at all during these times.
My mother had a very positive experience with telehealth during COVID-19. As a matter of fact, when she initially thought that when she was sick, but she thought she was the doctor, her first visit was telehealth. And within a couple hours, the nurses were there with hazmat suits on. So her whole entire experience was telehealth, but they were so hands-on. They were so aggressive in making sure that her treatment was right away. The medication that she needed was there timely. So the experience itself was a great experience. But what I have concerns are patients that have that don't have the access for telehealth, that live in low-income communities and don't have the necessary equipment. And so I've encountered patients that aren't able to do telehealth because they don't have smartphones, or their computers, they just don't have the bandwidth for that. So I would love to see legislation that would make sure that if telehealth is the way that we're going, that there's a mechanism that provides patients, and especially low-income patients, with the means to participate in telehealth, even if they don't have the means themselves. There has to be some type of program that that they can come up with, or that can help patients maintain that.
So I'm going to give a different perspective versus Brian. So as a medical oncologist and for our stage 4 patients, I'm providing recommendations to patients indefinitely at times if they're surgically unresectable. I have no idea why there's this halo all of a sudden the way the sun's setting. But anyways, so and also depends upon the state. So in Tennessee, for some reason, we're having some legislative issues where telehealth will not necessarily it's being considered, but it's not been, it's a bit of a discussion point right now, in all fairness. So I think it just depends upon the state where you're in, and if everybody agrees upon it. My understanding is that there is some reimbursement. Yes, I know that was an issue before of concern, and obviously I don't know if that will continue, but also I think we also have to keep in mind for myself, I run a lot of clinical trials. I don't have any trouble doing some of the visits via telehealth, but definitely some of the visits really need to be in the office.
Absolutely.
And so I'm a fan of telehealth, but also I still need to see the patient on some aspects. But I would fully agree with Candace. I would love to see the legislation be uniform across the United States. And not just one state versus another state, because to me that seems a little ridiculous. We're trying to optimize the care of our colorectal cancer patients. We're trying to help the patients. And just because I'm seeing a patient in another state doesn't mean I'm trying to steal that patient. I'm trying to help that patient, and if the patient can get their care, and if anybody that knows me, I allow the chemotherapy to be completed at the outside facility, if it's just a standard treatment and not obviously on a clinical trial. But I do like to see my patients for restaging if possible, because I do like to keep my imaging as uniform as possible. So I think there's pluses and minuses. But I do love incorporating telehealth, but I would like to see some uniformity.
Thank you for that perspective. Joanna, I think you had a couple of coincidental thoughts related to policy and insurance. Would you like to come in there?
Yeah, absolutely. So I definitely think telemedicine, the insurance coverage for telemedicine expansion has really focused on government programs like Medicare. There's been less expanded access in private insurance for things like preventive services. So there's been expansion around COVID-related telehealth appointments, but there's still not coverage for those basic medical appointments across all insurance companies. And then broadly across policy issues, some of the issues are the exact same issues that we've been advocating for as a cancer community. They've just really been brought to light as even more of a challenge in a COVID environment. So things like making sure that every state's Medicaid program will cover the routine costs for patients who want to participate in a clinical trial, which isn't currently required. It's up to the state. Things like preventing insurance companies from making patients go through step therapy to get access to the drugs that they need, or oral chemoparity, or making sure patients aren't facing surprise medical bills. So the cancer community's advocacy efforts have been focusing on trying to get Congress to pay attention to these issues, not because they're new issues, but because they're even more important now than ever.
And in terms of the regulations that have temporarily been eased up, do you have concerns about how that's going to change in the landscape of what the doctors might be reimbursed for and what the patients might be covered for?
I think that the changes to regulations have come so fast and so furious in an effort to meet the needs both of providers and patients, so that providers can meet patient needs. I think we're going to see some of the changes continue to last beyond COVID, and I think some of the changes might not because of concerns about reimbursement or sustainability. So it really kind of just depends on the regulations. I think that this environment has forced the healthcare community to look at the use of technology the way that many of us have had to look at the use of technology in different ways.
I would have to say that just chiming in regards to what you just mentioned, I'm a member of the Southwest Oncology Group. I'm the vice chair of the GI committee, and you know this issue's been discussed regarding what are the innovations we're going to do to help our cancer patients, especially in regards to clinical trials. And we've had a lot of discussion. I hope something will become of this, but we hope that you know, as Candace mentioned, there are individuals out that have difficulty getting necessarily to a doctor's office and can't get the health care that they really deserve. But yet there may be doctors in the community close by that can assist them in some way, so they could still participate in the clinical trial if we can find a different mechanism. Let's say if they're enrolled to the control arm of the trial, is there a way for them to receive that same care? It's a standard of care if they're in the control arm. Can they receive it at their local facility and yet still participate in the clinical trial? That would definitely help with clinical trial enrollment in some of these, for these individuals that can't travel or don't have the financial means to go to a facility to participate in a clinical trial. I mean, we have phone apps, we have telehealth. We could utilize some of the you know, local facilities for blood work and additional aspects to try to help with provide patient enrollment for clinical trials. And so I think there's a lot of possibilities as well. But once again, it's just a discussion that we're having amongst the Southwest Oncology Group, and I hope something will become of it.
Thank you again. Mike, for you here, and then maybe Candace, you could follow. Do you feel that during COVID there have been changes in your cancer care? And I mean, you've experienced cancer care before and during COVID, and in terms of your sort of senior cancer care team in person, etc., delays in getting supplies. What's your perspective on how that world has changed, Mike?
Yeah, for me, like my oncologist, they're requiring him to be at home 1 day a week, and it happened to be the day that I would go in for my chemo appointment. So every other time I get to see the APRN instead of him, but when I do have to go in, I have to flex and go in on Tuesdays instead of Wednesdays. So it's just that's the only real change there. I do get a second opinion from Dr. Saltz at MSK in New York City. So the telehealth has been very beneficial there. I don't have to take a day off from work and travel on the train to get to the city and, you know, deal with all of that. You know, for a 45-minute appointment, it was taking me a whole day to do it. So the telehealth is incredibly beneficial. But the biggest change for me or impact was getting my scan delayed. So when you're late stage cancer and you're making changes to your treatment plan, and then you want to see if it's working, and then you get delayed because it's not deemed a priority, you know, that's very nerve-wracking, because you want to know if things still growing and spreading, or did we do the right thing, and it's, you know, we're seeing the opposite result. So it does take a mental toll on you, I think, as a patient when that type of stuff happens.
Thank you, Mike. Candace, is there anything you want to add to Mike's perspective?
Oh, yeah. So today, I was supposed to be in surgery today to remove scar tissue. However, because of an increase of COVID-19 patients being in the hospital, that surgery was rescheduled. And so, you know, so these are things that, you know, that makes it difficult, because not only are you, it takes you a while, first of all, you're getting it through your head that you're preparing for surgery, you know, and then it's like, okay, now I'm headed for another surgery, you know, and so you're trying to wrap your head around that, and just to get to that point, and then for them to say, oh, sorry, we have to cancel it because, you know, the hospital has reached this, you know, has increased its patient base for COVID-19. So that kind of puts you in a totally different headspace, because I've had to work up to, you know, getting ready for this major surgery, you know, on my small intestine. And so it's been like, okay, so now I have to start to process all over again, and hoping that it's not rescheduled again in 2 weeks. The telehealth portion that's been the easiest part of it. Even with, you know, visiting with my primary care, we've had to do telehealth, but I still had to go into the clinic to receive my medication. So there's still an imbalance there, whereas as I can't come into the clinic to see the doctor, but I have to come into the clinic to pick up my medications, because, you know, that the laws have changed on certain prescriptions. They have to be picked up and delivered in person. So I think once with that, they have to find a way to make this work along with telehealth, because that defeats the purpose. If I can't come into the clinic to visit the doctor, you know, I mean, so that's been the challenge, you know, so I'm having to go out to do that. The telehealth portion, even going through going over the results from the scans that I had, the other tests that I had, everything was done via telehealth, and it was done efficiently and quickly. So that has not been an issue, but like I said, just having to go into the clinic to receive the medication, and then having my procedure canceled because of COVID-19, and I'm sure I'm not the only patient that is experiencing that. So you can imagine, you know, the difficulty it is to get yourself worked up for something just to have it canceled. So.
Joel, you know, I think that's a great question for you to ask. You know, how can we as patients kind of mentally gear up for these changes and shifts that, you know, we gear up to set ourselves for something that's a big procedure, and then it's that letdown and you have to try to gear yourself up again. What recommendations would you have for that?
So after initially being upset, you know, because I expressed the fact that I moved things around to prepare for this surgery, and asked, was this a matter of convenience for them, or was it actually something that, you know, was a protocol? Because if it was a matter of protocol, then I understand. If it's a matter of convenience for you, I have a problem with that, because I've adjusted my life for this. But then after calming down and having the conversation, because I had to talk it out, they had to tell me that it was protocol, because I was not accepting that you were telling me my it's canceled just because of this. It had to be protocol. And then I had to change my focus in saying that if it was canceled, it was for a good reason. And I have to trust that my health during this time is more important than the surgery. The surgery was not life-threatening. It wasn't for a life-threatening situation. But if I go in during this time, my situation could become life-threatening. So I had to weigh the issues that are at hand versus what I was going for, and adjust my thinking and say, you know what, I understand there was anxiety. And then after I realized that I was having an anxiety response, then I took a breath and then I called some friends to talk me through it so that I could kind of like, okay, there had to be a reason, you know, and because I'm spiritual and I believe that everything happens for a reason. And because of that, I was able to do this panel today, and some other things happened that during this time I wouldn't have been able to do if I was, you know, if I had surgery today. So I have to believe that it was divine intervention that allowed me to take care of some things that happened to come along as this got canceled. So, and some, you know, having voice of reason and someone to calm you down is very helpful.
And Joel, you know, I think there's a lot of caregiver support that we can certainly lean on, but you know, in terms of our own mental gymnastics to get through this, what would you like to add to what we can do to better navigate this mentally?
Hi, Fong, that was for me?
Yes.
Okay, yeah, you were breaking up there for a second. I mean, it's just exemplified, I mean, some of the core strategies that we see as being very effective in the research, and other people matter a lot, and reaching out to get feedback from other people to see if they're seeing the same thing you are, and helping you strategize. And then another factor that I heard that plays an important role, and this varies from individual to individual, but for many people, they need to know why. So let me understand why this is working out this way as opposed to that way. And oftentimes when you hear the other person's perspective, you'll see a bigger picture, and you'll go, okay, now I can work within that framework. So those two things in particular are very profound activities for addressing any type of barriers that pop in front of someone.
Thank you. I'm going to try and combine about 8 or 9 questions we've had, really, and they all relate to what you might describe as degrees of risk associated with stage of treatment or recovery or NED or early diagnosis, etc., relative to COVID, and how high or low risk someone might be depending on their status, if that makes sense. As I say, it's very hard to list all the questions. I guess, is there a spectrum of risk, if you like, going from early diagnosis, full treatment, right through to NED and 2 years recovery, etc.? So, Dr. Fields, could I maybe start with you for a perspective? Is that okay?
Yeah, I mean, I think big picture like that, I guess I would say that probably the larger your disease burden, potentially the weaker your immune system may be, and that probably goes in line with being on potentially more aggressive treatments. I wouldn't say that necessarily as a blanket statement, but at least to sort of think in big picture. I think, at least speaking from my perspective on the surgical side of things, we have not found an increased risk with COVID as patients are recovering from surgery. Now, that being said, I think in line with most medical centers, you're not going to come in and get an operation without testing negative for COVID first. So we know that it's a patient population that's tested, that's starting off negative. Our hospital, which you kind of see a virtual picture of behind, is about a 1,000-bed hospital system. And so far, at least as we've been able to trace and contract trace, have not had a nosocomial, a hospital-acquired infection from an asymptomatic patient spreading it through the hospital. And that's from testing people coming in and then following up with patients after hospitalizations to making sure they're not coming down with COVID. So I think at least surgeries and procedures, including endoscopies and others, I think are safe right now. At most medical centers are doing all the things to make that happen. And I think they're also going to great precautions for the highest risk patients, the bone marrow transplant patients, the real immunocompromised patients, to make sure that if they need to be in the hospital, that they're in the right place with the right protections, and that their treatments are make sense in sort of a risk benefit. And then once they leave the hospital, that they have a lot of good information about, do they need to stay quarantined for a while? If so, for how long? How often are they going to be checked in? Some routinely tested, those sorts of things. You know, every time I pop open a table of contents from a journal, whether it's the New England Journal or another, there's 10 new articles with new information about COVID and cancer, COVID and risk factors. So it's such a moving target, but those would be sort of from my perspective, the big picture things.
Thank you. Would any of the panelists like to add a different perspective?
No, I agree with Ryan. I mean, from my perspective, for a stage 1 through 3 colon or rectal cancer patient that's undergone resection, has completed their therapy, and if their energy levels return back to normal, I am not concerned necessarily about their risk of getting COVID once they've completed all their treatment and they're at least, a month out, let's say, from their therapy, because they're deemed already basically NED. It's the patients that I'm worried about that have stage 4 disease, or maybe they've had a metastatic resection of their liver or lung, even though they may have already completed their therapy or their adjuvant therapy. Those patients are still at risk, even though they've had a full resection of their liver or lung or whatever other site of disease, because their immune system is still going to be a bit suppressed because they are at higher risk, I would say. So a stage 4 patient is still my primary concern.
So along those lines, we have a question here for visitors that are coming to stay with you as things are starting to lift, or as you need people to come support. Do you think it is necessary to push chemo off a week and have them come during the 3rd week when immunity is at the highest?
From a medical oncologist viewpoint, once again, it depends upon the regimen that the patient is on, and also what have their blood counts, what have they shown before. So from my perspective, if there's never been a decline in the white blood cell count when the patient was on treatment, I have no concerns as long as the family that's visiting, number one, within a certain number of family members that's reasonable to come visit, and to make sure that they obviously are fairly healthy themselves. I am not that concerned. I don't think that treatment necessarily has to be held off a week. But once again, I will look back historically at the patient's counts and take that into account when I think of that.
Okay, I've got a question here for Joanna. I think it builds on something you were talking about earlier, but very bluntly, how is a cancer patient protected in the COVID-19 arena in job security terms? Is there protection, for example, under the American Disability Act? So that's a general question if you have a perspective there.
There are some very useful protections. I think for most people who've been diagnosed with cancer who are eligible for protection under the Americans with Disabilities Act or a state fair employment law, you have access to something called a reasonable accommodation, which means that you can ask for adjustments. Many of us are actually already working under those types of adjustments. So people who are working from home rather than working from the office, telecommuting is a potential reasonable accommodation. So if it's reasonable based on your job responsibilities, you could continue to do that even though you might be being called back to work, for example. So looking at your options under the ADA, if you actually need to take time off because you can't be accommodated and be comfortable in the workplace, there's the Family and Medical Leave Act, there's state leave protections, but there are also the new ones related to COVID. So there's paid sick leave and there's paid family leave. And those are beneficial both to patients who want to take time off for themselves, but also for caregivers who are concerned about going to work and then exposing their family members or their loved ones to COVID. And so we actually laid out those different laws and how they apply differently to patients and caregivers in our blog. So at triagecancer.org/blog, we've done some extensive explanations of those employment protections there.
Yeah, and I would add to that, just for complete transparency, for me, I actually submitted and have a job accommodation approved through my employer. So, and it's for things like, I was just reading it today, the understanding to be provided when struggling with memory or focus. The understanding will be provided if you become easily overwhelmed by workload. Provided time to work through things when necessary. Frequent use of the bathroom as needed, and time off to attend medical appointments. And then it gets, I have to resubmit more paperwork from the doctor in August when it needs to be re-reviewed. But that is just something that I have in place with my employer.
Accommodations, I think, are the most underutilized tool that the law provides to help people, and not just to work through treatment or return to work, but also to actually take time off. So taking time off could be a reasonable accommodation. And we have an endless number of resources to help people navigate accommodations.
Yeah. And the other advice I would give is help your medical team with the paperwork. They don't always know what to write. You can help them with that.
Mike, you've hit on one of my soapbox issues, because most of the time patients just take the form and they hand it to someone in their oncologist's office, and they don't have a discussion about what their preferences are and how they get filled out, or even disclosure decisions, because you have choices in how much you tell your employer about your medical condition. And so we have tons of resources around disclosure choices as well.
Dr. Malin, I have a question here for you. This person is dealing with the complexities of cancer, and then you have the uncertainties of COVID intermingled. And basically, it's like we fight every day against cancer only to have COVID slip in the back door. So how do we continue to work within the COVID framework while fighting cancer, while trying to live a life, because it is as if COVID took quality of life, quality of living life away even more for cancer patients?
Yeah, well, there's a lot there, isn't there? Typically, what we see among folks who are experiencing numerous major life stressors, for coping strategies, the primary route at that point is a very narrow focus on the day-to-day. I mean, some days bringing the mail in is a major accomplishment. And so setting your goals appropriately in the context of cancer and the pandemic, and you may have a couple of other things to add on top of that, to realize that you're not alone. I mean, these groups, like tonight, is a clear example of where you can gather and experience some of these things together. But to realize that some days it's okay to not get off the sofa. And there's certainly a lot going on right now, and to have some self-compassion will actually matters a lot. So narrowing your focus to shorter term, day-to-day goals, and realizing that some days just accomplishing those are important and are enough.
If I could just say one thing, I think big picture, and I think, you know, this is normally when a patient is going through something or there's a crisis, you know, somebody on one side of the table or discussions having the crisis, and the other person sort of the caregiver, or the expert, or the treating physician. But you know, COVID, we're all going through this together. The physicians and the providers are as new to this as everybody else. Our lives, although not on the same way, different from a patient that's diagnosed with cancer in this era, our lives and changes and restrictions are certainly different than they were several months ago. I have talked to patients now about coming in to have major surgery, but not being able to have a visitor in their room. These were never conversations we had before. And it's, I've never had to talk about that, and I've never had the patients have never sort of heard that. So we're very much in it together in a partnership, trying to navigate through it as best we can. And we're events like this here in perspective of people from all aspects of it are really helpful in us trying to make it work as best we can. I mean, I've you know, done telehealth visits in my basement in my pajamas at 6 and 7 in the morning because it's worked out for patients that way, where, you know, I could never even do that in the office if I wanted to, because nobody would come in and open it. So there's a lot of things that we're doing that we never would have thought of 3 months ago that maybe we'll keep doing in the future. And there's ways to, I think, get through some of these limitations together that are really important. And one thing I would just advocate to everyone and their patients, it seems like a no-brainer, but as Candace was saying, you know, when you have something that changes, a surgery gets rescheduled and it's unclear why, you know, certainly ask anything that's unclear, because most of the time, I would say, hopefully all the time, when things are happening like that, they're because something happened in the hospital that demanded it, or there was some schedule change or something. But oftentimes it may not be communicated as well as it needs to be.
And I'd like to add something to that. You know, especially from the patient perspective, give yourself permission. So often we are dealing with challenges just being a patient. Then you add life, you add family, you add work, you add everything else to it, and then you at COVID-19. And so we feel as if we have to maintain, this stand-up, statuesque vision to people who see us every day, because that's what we're used to. But give yourself permission to be angry, to be frustrated, to be upset, to all of it, whatever emotions that you have, give yourself permission because it's valid. And then once you do that, my family and I, my cousins and I, we had a Zoom watch party. And I can tell you, we didn't watch the movie. We talked more on Zoom than we did watching the movie. But the fact of the matter was that we all came together to help each other get through this. And so find you someone or a group of friends, family members who's willing to go on this journey with you of self maintenance, because that's what you're doing. You're maintaining because you don't have access at the moment. So have someone that's willing to walk with you on this journey, saying, I really need somebody to walk with me, to talk with me today because I'm struggling. And be transparent to let people know you're struggling, because I think so often we're so stigmatized by mental health challenges because of what we've seen, out on images of television and what people say and how they judge us, that we fear that people may judge if we say, I'm having a mental health moment. This is the time to say, I'm having a mental health moment and I need you. So be vulnerable enough, be transparent enough, and then be forgiving enough to yourself for having a weak moment. And honestly, it's not a weak moment. We're all struggling. So this is not a weak moment. It's okay. And I think that's what we forget, to give ourselves permission not to be okay.
Thank you. Thank you for those rich words, Candace. We had a couple of video questions on standby in case you guys didn't come through with questions, but we've absolutely been blessed with many, many questions, but I do want to give some space to the video that was pre-produced. So, Devin, if you could run a question that I think is on everyone's lips, whether they're involved with cancer or not.
Hi, my name is Perry Jones. Thanks for taking my question. I live in Oregon City, Oregon, and I was diagnosed with stage 4 colon cancer at age 46. If and when a vaccine for COVID-19 becomes available, how far down the list of the population do you think I will be as a cancer patient? I've heard that as vaccine manufacturing ramps up, the priority will be to get the first vaccines available to more vulnerable people such as healthcare workers and the elderly. I'm curious if you think whether immune-compromised cancer patients such as myself will be included in those considered most vulnerable, or will we have to wait until the vaccine is more available to the general population? Thank you.
It's a great question. I'm going to throw it open to the floor and see if someone wants to pick that up.
I don't know if we know, but I think a lot of it has to do with the scale at which they can produce a vaccine, which will have to do with what type of vaccine it is and how quickly the production can get ramped up. But I think in general, we're going to see it prioritized most likely to the hospital workers and people on the front line who need it to work safely and then take care of sick patients. And then, as was alluded to probably more vulnerable populations who may need it because they have to get back to sort of more normal function. The one thing I would say, I guess I'm very encouraged by having a few close friends who are in the midst of all the vaccine efforts, is that the economy of scale of which I think some of these vaccines can and will be produced, if there's a successful one, I think are going to be shockingly rapid, in the sense that I think there will be mass production of them quickly. So it may not be as much of a rationing issue, I hope, as we may think. But I think it's a real uncertain question, but an area of obviously interest to all.
That's a great perspective on a difficult question, really. So I appreciate that. Did you want to?
I was going to see if any of the other panelists wanted to add to that real quick before we.
I mean, I agree with Ryan. I don't think we know exactly how the prioritization is going to happen, other than the fact that I presume healthcare workers will be provided vaccination early on, just because of the degree of exposure, and just because we obviously are taking care of patients, and if you know, we don't want to expose other patients as well. So I suspect that will be the case. But in regards to prioritizing which patient populations, I would hope that cancer patients would be high priority. I would presume that would be the case. But once again, you know, I don't know if we know for sure exactly how it's going to be decided, but I agree with Ryan, it's going to be mass production. So I'm hoping that it will not be so much of an issue.
Well, this has been amazing, and with all the questions that we have, you know, sorry that we didn't get to everybody. We'll definitely have follow-up on those questions that were left unanswered here in this call. So look for that follow-up. But we'd like to wrap with a little bit of just some words from Dr. Malin here, who can perhaps share some insight as to how we can survive this as a community, and what reliances we can hold to on ourselves as well as each other.
Yes, Fong, I know you wanted me to help end on a high note, and certainly I can speak a little bit to the research field on resiliency and what's called post-traumatic growth. Resiliency is the process of bouncing back from adversity and ending up where one was before the adversity struck. Well, you know, a lot of the things that everyone's dealing with right now are not short-term things. These are things that it's going to take some time to get through. So of course, these resiliency factors probably matter more. And then most people are aware of the concept of post-traumatic stress disorder. And when it comes to negative life events, oftentimes they assume that they're doomed from a mental health perspective. Well, the research literature is quite surprising on this front, where the majority of cancer survivors actually endorse the concept of post-traumatic growth at a much higher rate than post-traumatic stress disorder. And post-traumatic growth is actually operating at a higher level than where one was before the event occurred. In no way am I wishing negative life events or cancer on anyone in order for them to grow or become a better person. But what we do know is it seems to be part of the process of adaptive coping. And humans are naturally storytellers. You know, they like to tell their story. And I was reading an article about the pandemic, about how, you know, when we grow older and the pandemic has passed, younger people may ask, well, what did you do during this time frame? And so that's kind of a framework of post-traumatic growth, is looking at the situation you're in and asking yourself, what are the opportunities here despite these limitations that are being placed on me? And the post-traumatic growth literature shows 4 or 5 different areas. And I'll go through them very briefly because I know we're at the end of our time. Relationships is a big area. So what relationships can you connect with and improve? New possibilities in life, what do those look like? Obviously, there's the concept of appreciating life, slower walks and actually stopping and smelling the roses, so to speak, but this is also a here and now focus. Finding that courage and personal strength to address the challenges that you have control over. And then lastly, for those who are so inclined to spiritual change and spiritual development and focusing on those areas. Those are some key areas that are noted in the research on more positive trajectories following negative life events. Sorry to be so academic, but in 2 minutes, that's a crash course in all the different things that can happen in a positive way.
That's great. Listen, this has gone so fast. It's a shame that we need to wrap up. I mean, the quality of the questions and the answers has been fantastic. I never fail to be inspired by the power of the patient voice. And I think if you can add compassionate expertise into that mix, then it just makes us unstoppable as a community. So true, sincere thanks to me for all of our experts and our patient community for firing in wonderful questions and answers. I think I speak for Fong and myself and say we want to do this sort of thing again. So do watch this space, but I don't want to hog the mic because I know we need to close down. So Fong, do you want to add anything to that?
Yeah, just echoing your remarks, this has been tremendous, and I love when patients and doctors can have these real conversations together, because I feel like we just get so much further and gain understandings of each other's perspectives and worries, and sometimes that's enough to really change the relationships. So I thank you all as well for attending, and definitely look out for more from us together. Sharon, shall we send this back to you?
Sure. Yeah. Thanks everyone again for joining live, and thank you to our wonderful panelists. You guys were great. We do have a ton of questions that remain unanswered. We have them. We will answer them. We will get back to you. The session has been recorded, so we will send a follow-up email as well with the link so that you all can watch the recording. And also in that email, keep an eye out. There's a short survey in there for you. We'll also include some resources, including the wonderful ones that Joanna had sent over. But yeah, thanks again, everyone, for your time tonight, and stay safe, and we look forward to doing this again. Bye, everyone.